kind of thinking to dermatology, we do have a lot of different chronic diseases within dermatology.
What we're thinking, and I know there's still some debate about this to a degree, in developing consensus on what's considered remission for eczema or atopic dermatitis or even psoriasis now.
Yeah, so I think something really important happened actually just last year. Active disease is going to be that active visible flame, right? That's your plaque, that's your symptoms, that's your itch, that's the flares. Your medication is like a bucket of water.
Too, and I know we've talked more psoriasis. Like, what about in the eczema, atopic dermatitis space? What are you seeing there?
Welcome to Derm-It, Trotter. Don't swear about skincare, where host Dr. Shannon C. Trotter, a board-certified dermatologist, sits down with fellow dermatologists and skincare experts to separate fact from fiction and simplify skincare. Let's get started.
Welcome to the Derm-It Trotter Don't Swear About Skincare podcast. On today's show, I've got Dr. Joe Tung, board certified derm, medical director at the University of Pittsburgh Medical Center, Falk Dermatology. He even directs clinical trials where he does a lot of research with new medications for all things skin. And he's associate director of the dermatology residency program, so he even loves to train future dermatologists. Welcome to the podcast, Joe. It's great to have you here.
Thank you so much, Shannon. I think you're doing such a great thing with this podcast, and it's an honor to be on today.
Well, thank you. It's great to have you here as well. I'm excited to really hear your thoughts on kind of what we want to talk about in dermatology. And I think what we wanted to hone in on the topic is skin disease in general and talking about how chronic it is and the thought of remission, that we can actually put certain skin conditions like psoriasis, eczema, we can actually put these bad boys, as you will, away for long periods of time so people actually do well with their skin. But first, I want to talk to you about what does it even mean to have a chronic disease? Because I think this is something that can be hard for the dermatologist to explain sometimes, but then also for patients to truly understand as well, just what chronic means.
Of course, I think that's a really good place to start as well, Shannon. So I think most of us would agree with the official CDC and WHO definition of chronic disease, which is usually any disease that's at least 3 months in duration or longer and generally requires ongoing management. And so when we apply that kind of thinking to dermatology, we do have a lot of different chronic diseases within dermatology. 1 in 4, in fact, so if you think of your 3 best friends, in the room, 1 in 4 of them will have a chronic inflammatory skin disease. Of those, you think about the ones that I see day to day in my clinic, those are things like eczema, 30 million American adults, up to 25% of pediatric patients with eczema at some point in their life, 7.5 million Americans with psoriasis. Then you think about diseases like hidradenitis suppurativa, one of the most devastating things I see day to day in clinic. And then, of course, vitiligo, chronic spontaneous urticaria. The list is pretty long here, Shannon.
Yeah. And I think, for a patient, when they think chronic, they're like, oh my, like, what does that mean for me? And I think what you and I appreciate is that they're more challenging sometimes to manage, and the thought that we don't really, cure them, right? Like, we're not going to necessarily offer a cure as much as we have tools to control disease better. And it's scary how many chronic conditions we treat, like just something as simple as acne or even rosacea or even precancerous lesions called actinic keratoses, or even in that chronic bucket. It's good job security for us, Joe, but frustrating for patients, I think, too. Why do you think it's so important for patients to get an idea if something's chronic? Because I do think for them, when they hear chronic, they think, oh my, what does that really mean? And I don't know if patients always get the idea when we're trying to educate them what chronic means to us.
I think that's a really good point as well, Shannon. So I think the point of chronic is really important because of some of the clinical implications for our patients. I like to take a step back and think about diseases like high blood pressure or diabetes. And in clinic, this is the way I explain chronic inflammatory skin disease to my patients as well. Nobody really expects, to take your blood pressure medication for 3 months and then, your blood pressure is under decent control. You stop the medication and all of a sudden, your high blood pressure is cured, right? We kind of understand intuitively that the medication is controlling the disease when you're on it. But once you stop, your blood pressure is going to go back up. But when you kind of take that mental model over to inflammatory skin disease, I do think there's a big education gap there, among providers as well as among patients. One of the recent things I read recently, Shannon, is that roughly half of all dermatology patients stop their dermatology medication within 8 weeks after starting it. 8 weeks. And when you take a look at the number one reason, they saw improvement with their skin disease, they assumed the disease was cured, and they stopped the medication. I think that's a big, education gap, but also a failure of communication on the side of healthcare professionals. But here's why it really matters, Shannon. We know that a lot of these chronic inflammatory skin disease, they're not just skin-related diseases. They're really systemic disease. If you take something like severe psoriasis, we have really good data to show that patients with severe psoriasis actually have an 80% increased mortality risk. On average, their lives are 5 years shorter than those without the severe psoriasis.
Mhm.
Depression rates are much higher. Suicidal ideation is much higher. So I think one of the key points here is that understanding that these diseases are chronic is what motivates long-term treatment engagement. And this long-term engagement is what really produces some of these more life-changing outcomes for our patients.
Gosh, I just really like what you said there and kind of want to hit on a few points there to illustrate. One, I have a patient, we'll just call him Bob, name not clear enough, Bob, but he said the example you mentioned, he has high blood pressure and he came into our clinic and we were reviewing his medication list. And I said, "Oh, I see you're on this medication. I know it's used for high blood pressure. Do you have high blood pressure?" And he said, "No." He's like, "I don't have high blood pressure at all." And I said, "Oh." And I said, "So what do you use it for?" And he's like, "Well, I used to have high blood pressure before I treated it." And so the assumption was the medication cured him, where I said, "Oh," I said, "Well, technically, we still consider you as having high blood pressure. It's just the medicine you're using is now controlling it. So your blood pressure is back into a normal range." And I said, I think that sometimes happens, like you just mentioned, with chronic skin conditions like eczema or psoriasis. We get a medication, skin's looking fantastic. So the assumption is, oh, the medicine must have fixed it, right? And you and I know differently, it's controlling it. And so keeping on the medication, potentially, yes, lifelong for a lot of these conditions, or at least extended periods of time, is what results in that control. And it doesn't mean we don't have options to change it up. As you know, with some of our newer medications, we're looking at different dosing strategies. People believe less medications more, but it doesn't mean none of a medication, to maybe keep our skin condition in check. So I think that's really a good point you make, really on the patient side, to highlight, hey, it's the medicine that's keeping it away, not some magical cure. So it'd be important to stay on it, and the provider setting those expectations for patients too, so they don't just stop things out of the blue. I'm sure you've experienced it too, where somebody has stopped a medicine because they thought their psoriasis was gone forever or their eczema was, and lo and behold, it definitely came back. Have you experienced that scenario?
Oh, every day, Shannon.
Mm-hmm.
No, I do think that paradigm is starting to change, where now, we are thinking more about this concept of remission and what that looks like,
Mm-hmm.
to segue to, thinking about cures in
Yeah.
the future. So I do think, like you alluded to, some of our newer biologic agents, does have some good data that I, would love to discuss, in terms of remission.
Mm-hmm. Yeah, and remission, I want you to kind of talk more about that, because I think a lot of people hear remission, and the average person, probably listener out there, might even think, especially if they're not in healthcare, I think of remission in cancer, right? That's probably their first thought when they hear somebody's in remission. And this concept that we could have remittive or effects, or somebody could be in remission from their skin conditions, kind of new or novel, I think, for patients and even for providers that may have been practicing for a while, because we just didn't have medications at our disposal that truly did that so well as what we have today. So, definitions are important. So I was going to have you kind of just talk about definitions of what we're thinking. And I know there's still some debate about this to a degree, in developing consensus on what's considered remission for eczema or atopic dermatitis or even psoriasis now.
Yeah, so I think something really important happened actually just last year, Shannon. So in 2025, the National Psoriasis Foundation actually gathered close to 100 different experts together and for the very first time published a consensus definition of remission for psoriasis. That definition is this: 0% body surface area affected, sustained for at least 6 months while on treatment. Okay, so again, 0% body surface area, so complete clearance while on treatment for at least 6 months. That's the definition for on-treatment remission. Now, the holy grail, off-treatment remission or drug-free remission, I think that's where the disease stays quiet after you stop the medication entirely, again, for 6 months to 1 year period.
Mm-hmm.
For atopic dermatitis, though, that we don't yet have that same level of formal consensus in the field yet. But for me personally, it's a similar definition, really trying to achieve complete clearance from my patients, whether it's on therapy remission or off therapy remission. And I think, this definition, which, millions of people in the United States affected by psoriasis and eczema, and really just coming to a consensus on the definition over the past year, I think that's really important, because the first step to solving any problem is really knowing, what it is that we're targeting, what we're going after, right?
Mm-hmm. What are your thoughts on kind of the whole stop medication? Because I have a lot of patients and some of those listeners out here that they may have been on a biologic for their psoriasis now for a while, been perfectly clear for years, or they may have atopic derm experiencing, the same benefit from one of our therapies that are out there. If they're in remission, how do you talk with your patients? They're like, hey, Joe or they'll say, Dr. Tung, I definitely want to stop potentially this medication. This is not for me, Dr. Tung. I think I got to do something, or go off of it because I feel like, I'm doing really well and I'd prefer to be on less medicine. How do you handle that question right now?
And that's probably the number one question I get in my clinic for my inflammatory skin disease patients. Before anything else, they're like, look, Dr. Tung, how long do I need to be on this medication for? So the analogy I use here is thinking about a bonfire. Okay, so we think about a bonfire here. The active disease is going to be that active visible flame, right? That's your plaque, that's your symptoms, that's your itch, that's the flares. Your medication is like a bucket of water. So you throw the bucket of water over this flame and you can, on the surface look like the fire's all completely put out. That's remission here. That's on treatment remission. Looks like the fire's out. But what we know from science is that firewood underneath, they're still hot. There's still tiny little embers within that. So if you walk away too soon, that fire does start right back up again. That's the story, I've been telling my patients up to this point. But Shannon, over the past year to 2 years, I think that paradigm is really starting to change with some of our newer agents and some of these newer research studies.
Well, I know people don't always love to hear studies or about the data. I know you just kind of provided the perfect segue to that. But there was a study for psoriasis, kind of has a cool name, knockout study, which I love, and I think patients would appreciate that as well. I wanted you to break it down, like if you're talking, to a patient, what are the, the findings from this, and what does it really mean for you and maybe how we're going to treat your psoriasis?
Yeah, there are actually two studies I would love to talk about. The first is that knockout study. The second one is a complementary study called the guide study. So remember that fire analogy we just talked about, right? So you have the firewood staying hot even when the active flames are out. Why is that? The reason for that is because there's a specific immune cell called your tissue resident memory T cell. I'll call it memory T cell just for short. These cells basically camp out permanently in your skin and they restart the inflammation when they're triggered. Our biologics can kind of silence them, but they don't eliminate these memory T cells completely. That's the fundamental reasons, plaque psoriasis comes back and oftentimes in the same spot, right? You see a lot of these patients who kind of come back and their flares are always in similar spots. For instance, I have one patient, I see every year around this time, around tax season, he works as a tax accountant in Pittsburgh. And, when he gets really stressed out, when it gets busy, March, April, tax season, he gets a flare of psoriasis, exact same spot right behind the ear, every single year. So why is that? That's because your memory T cells living, in the surface of the skin there. So now, onto this knockout study. This was published late last year. What the investigators did was they gave high doses of one of the FDA-approved psoriasis medications called risankizumab at doses up to 4 times the normal dose, but at just 3 time points. So you get at week 0, 1 month later, you got your second dose, and then 3 months after that, you got your third dose. Then they stopped the medication altogether. Now, about 8 to 9 months from that last dose of medication, they observed that 3 in 5 patients, about 60% of patients, were still completely clear or almost clear. Almost 2 years later, after their last injection of medication, 2 patients still remain completely clear. And I think this is the part that was really interesting, okay? So when they biopsy the skin on these patients, the memory T cells, those that remain in the skin and cause the inflammation, those were reduced to levels of completely normal, healthy skin. So the high dose of medication didn't just put out the fire, it removed that firewood completely. So I think that's the first study that really gave us some thought. Of course, the caveat here is that it was just a 20-person study with no placebo group. So as a proof of concept study, I think it's quite significant. But of course, a lot of additional work still needs to be done here. The second study that actually complements this is a study called a guide study. It got a little bit less attention, Shannon, just because most of this study was done in Europe rather than the United States. It used another one of our interleukin-23 agents, guselkumab, also FDA approved for moderate severe plaque psoriasis. And this was across 80 different centers, hundreds of patients in Germany and France. It also had 3 phases in the study where patients first got injections, and then there was a second phase where there was dose de-escalation. So they started spacing out this medication more and more for patients. And then there was a third period of complete withdrawal where patients stopped guselkumab injections completely. Those who achieved complete clearance, they call them super responders. They just didn't get any more medication after that. And a little over a quarter of these patients, so over 25% of these patients, did not need any treatment with injections 1 year later. I think that's pretty meaningful. But what's really exciting about this one study is the exact type of patients who were able to be super responders and then maintain clearance off of treatment. What the study found was that those patients who received treatment really early on in the disease course, so patients treated within the first 15 months of their very first symptom, those were the patients who had the longest period of treatment-free period. So those were the patients who were able to achieve this off-therapy remission at the highest rate. So I think the message is pretty simple between these two studies. We have a pretty narrow window of opportunity to really treat these patients early on in their disease course. And if we miss that, we might be playing catch up for many years afterwards.
Yeah, and I think it illustrates to the immune system, is kind of like somebody who's been doing something for a while, right? That old saying, you can't, teach an old dog new tricks, right? Maybe
Yeah.
the immune system is the same way. Once it's fallen into those patterns, it's really difficult to persuade it to kind of go back to sort of the normal state of where we'd want it, especially if we want to achieve kind of what we're seeing for remission. But really important, as you and I know, with any inflammatory skin condition, people tend to do much better when that fire first starts, right? Versus if it's been smoldering or burning for a while. And I think it's just fascinating because it shows us how the immune system can be very, relatively dynamic, but then also the persistence of it once things have really gotten started there. So I think that's exciting to kind of see, and, also with the data encouraging people, we suspect they have an inflammatory skin condition or their family doctor does, to get them into dermatology so we can really address this early on. We know better outcomes exist with that too. And I know we've talked more psoriasis, like what about in the eczema, atopic dermatitis space? What are you seeing there?
Yeah. So one last point here, because I think you really
Yeah.
hit the nail on the head there. So there's this concept that we consider epigenetic scarring, right? So we have
Mhm.
genetics and we have epigenetics. And this concept of epigenetic scarring, where the skin cells accumulate these molecular changes over time that lower the threshold for inflammation to restart, I think that's a really important concept, right? So for a lot of us providers, when we have visible changes, for instance, in diseases like hidradenitis suppurativa, where after a period of time you start to see the scarring, the tunnels, those patients, we can tell that they have architectural change, and those patients become a lot more difficult to treat medically. But for some of our more common inflammatory skin diseases, things like psoriasis and eczema, we don't really associate the same in terms of scarring, but we know on an epigenetic level, those patients, are harder to treat. So I think for patients, it's important to really recognize disease early and get in to see a dermatology provider, get started on advanced therapy earlier. And then for providers, I think it's also really important that, we really have this narrow window of opportunity. We don't have time to really play around. We have to be aggressive with therapy. We have to achieve
Mhm.
that a goal of getting to clearance as fast as we can for these patients with inflammatory skin disease.
And I
But
think
speaking of eczema as well, there's a lot of data. Atopic dermatitis does tell a little bit of a different story here than psoriasis. Part of it is because, we have a lot of different factors with the environment really coming in with eczema. About 30% of our AD patients will have a genetic mutation in one of the proteins called filaggrin as well. So think about that as, having these buildings with holes in them. Okay, so even if you put out the fire perfectly, these triggers can continue to get back into the skin. And so the remission bar is a little bit higher with our eczema patients. With some of our newer biologic agents, though, we do see some of this data around remission. So one of our new biologic agents, lebrikizumab, actually had patients who were responders. They also stopped the medication 4 months into treatment. And of those patients who were initial responders, over half of them maintained a near complete clearance of their skin 8 months after discontinuation. So after 4 months, didn't get a single injection after that. At the 1 year mark, over half of patients were still maintaining a close to complete clearance state. And this pipeline is also moving really fast here. We now have clinical trials looking at extended half-life biologics within the eczema space. We have new mechanisms like regulatory T cell therapies aimed at producing true immune reprogramming as well.
Well, and it's just exciting where we're going with that, that we can have potentially, that impact on skin conditions. And when you mentioned the epigenetic scarring, I wanted to circle back to that just for a moment, because you mentioned how important for providers to recognize, that can occur and there's a need to intervene early. I think, bringing that up to patients on a level that makes sense. We talked about maybe, teaching an old dog new tricks. I think it might help patients understand, why do we talk about systemic therapies earlier on in disease? I mean, obviously sometimes we're limited in how some of these medications are approved approved by the FDA, but progression, right, of certain conditions, and even its progression, that memory component, of the immune system, it's powerful, to really lead to disease that could be potentially worsening, or like you said, harder to rein in down the line. So I think explaining that to patients is helpful, where, I get it. Patients are going to be reluctant, right, to do some of these systemic therapies, whether it's just the thought of being on something more lifelong or long term. Maybe they are afraid of injections. Maybe they're intimidated by side effects potentially. So I think if we really explain to them, here's the rationale, like this is the reason why, because your immune system, once it kicks in and you've had this condition longer, your immune system is really hard to convince to go back to a normal state. But if we catch it early enough, we can maybe persuade it a little bit faster to come back to baseline and give you better control over your skin condition. So love that you highlight that memory part, and I definitely think important for both providers and the patients to get that concept. And I think we can intervene earlier with better outcomes potentially for patients as well. But with the remission, Joe, one of the things, love the concept, love where we're headed with it. But I think people are worried about, will remission really mean remission for me, right? Because we know inflammatory disease is very well impacted by the things around us. Stress, maybe even a genetic component. We've talked about the epigenetic component, but also, people wonder about other triggers that could override a remission. So I wanted to get your thoughts on that and kind of see how you feel like we might handle that in kind of this new era of how we treat inflammatory skin conditions.
For sure. I think all of the things that you just talked about, they're so important when we think about the patient as a whole, right? So we have genetics, stress, environment, they all play a role together. And I kind of think about this in terms of, this is an analogy I use for my patients because I'm a poker player. So I use a poker analogy here. Genetics is kind of like that starting hand that you're dealt. Okay, so you inherit them from your parents. So unless you change your parents, you're not going to change your genetics here.
Mm-hmm.
For instance, there's a genetic variant in psoriasis called HLA-CW6. If you inherit that genetic variant, your risk of developing psoriasis off the bat is already 20 times higher than someone without that genetic variant. Not 20% higher, 20 times higher. Wow. So for eczema, there are similar mutations. We talked about filaggrin a little bit, and those are that's the hand you inherit. The epigenetics is kind of like that environment around the poker table, who's sitting next to you, what their cards look like, whether the room on that day is loud or calm, aggressive or reserved. That's the environment. And the environment really can rewrite how your genes get expressed. Chronic inflammation, we talked a little bit about epigenetic scarring as well. That's where the epigenetics come in. Depends on the environment around you. Now, we just talked about a little bit about the triggers as well. Triggers are kind of like the cards on the table that get flipped over. Those are the specific things that can really modify the way that your genetics and your epigenetics interact to cause disease, right? So we know there are specific triggers for patients. Stress probably being the most powerful one. Over half of psoriasis patients identify stress as one of the triggers. Remember that patient I talked about earlier, the accountant in Pittsburgh, every year around March, April, when they get really busy, start getting the flare of psoriasis. We know stress is a big trigger for that patient and for a lot of other patients I see in my clinic as well. Now, the other kind of major triggers, we know infection being one of them for both psoriasis and eczema. Diet is also a big trigger. There was a lot of recent publications around specifically, highly inflammatory diets, high in processed foods, high in your saturated fats, sugars, salts, that can really tip the immune balance as well. And there was a trial that was just published in one of our premier dermatology journals, JAMA Dermatology, that looked at Mediterranean diet in psoriasis and some of our inflammatory skin diseases in particular, that showed significant improvement. All of these, are not replacements for medication, but they are real kind of modifiable factors that belong in the same conversation.
Well, and I think that's what people, would think of. Maybe remission is going to be perfect, but as you and I know, there are things that can override that state, and all the things you just talked about are great examples of this. So I think that's the one thing we have to, again, caution, patients to say, yes, we can potentially provide this, but there could be times where things kind of go off, and then there's a little, blip, if you will, on the radar where things might flare up. And they're just things that are sometimes out of our control. But one thing that may be working for controlling, I think disease more is this concept of Tregs, and a lot of people might be like, what the heck are Tregs? So I was going to have you comment on that just briefly. What are they? What are their potential role? Potentially the future, as we look for psoriasis. We've kind of talked briefly sort of about this, but I wanted you to dive in just a little bit deeper in our last few minutes here.
Of course. So we've been talking about the fire analogy, the bonfire this entire time. So let's stay consistent with the fire analogy here. So your regulatory T cells are kind of like the firefighters in your body. Okay. So their entire job is to show up when the immune system has gone a little bit too far and you're getting this active inflammation. And these regulatory T cells, they're the firefighters. They show up, they calm things down, prevent the building from burning down. This is actually a really timely topic, Shannon, because as you know, 2025, this most recent Nobel Prize in Medicine and Physiology just went to 3 scientists for their roles in discovering regulatory T cells. So this is one of the hottest areas in all of medicine right now. Here's the key number for a disease like psoriasis. In a healthy person, your regulatory T cells suppress inflammation with about 94% efficiency. In psoriasis patient, those regulatory T cells, their efficiency is around 70%. So that 24% gap, that's that disease process right there. The firefighters, the cells are there, they're just not doing their job properly, and that's what's causing this highly inflammatory state. So then, of course, the research question here becomes, can we train these firefighting cells, these regulatory T cells, to actually target disease a little bit better? So some of these studies are looking at using low doses of interleukin-2. Interleukin-2 is this molecule that's kind of like the food source for our regulatory T cells. A very small dose of it can preferentially stimulate these regulatory T cells without really stimulating the rest of your immune system. So there are studies in both psoriasis and eczema with pretty good and promising early results with stimulation of regulatory T cells. Other companies are looking at things like engineered peptides and these nanoparticles, basically particles to try to reprogram your immune cells toward a more peacekeeping role. And these can be delivered via very novel mechanisms as well, directly to the spots that are inflamed.
I mean, that's exciting. You got firefighter cells that are going rogue and we're correcting them. So I think that's going to be exciting for how we, really get those back in check with the technology that's available and what that's going to mean too with the whole concept of remission. I mean, time will tell, but we're headed in the right direction. If you think of remission, I just, in short, kind of was sweet to end this for us. Do you feel like it's really possible? And secondarily, what do you think are the pitfalls of remission?
Yeah, Shannon, I think not only is remission possible, but it should be our goal. And I kind of take a step back and really think about how far we've already come in terms of treatments for our chronic inflammatory skin diseases, right? 10, 15 years ago in psoriasis and eczema, if a patient came back into clinic, at their follow-up and they were 50% better, we were happy with that, so we were happy with any kind of improvement. Nowadays, and I tell all my patients this as well as my colleagues, my goal is 100% complete clearance of their skin. If they're coming back in, they're still flaring, they're still active, I'm not satisfied there. And I do think we have new biologic agents and JAK inhibitors that can get us to complete clearance. But I think over the next 5 to 10 years, Shannon, that conversation is really going to start shifting again, where clearance is not going to be enough for our patients. Our goal really will be more sustained remission, whether it's on treatment remission or off therapy remission. That should be our kind of the next frontier that we're targeting. And I do think, we're well on our way there. We can already see some of the early signs of, medications, whether with some of these withdrawal data, whether with different dosing regimen. I really think that, we're well on our way there. Now, in terms of the second part of your question about pitfalls, I think with any advances in therapy, one of the main pitfalls is really thinking about this notion of access to care, right? If remission becomes achievable for our patients, we need to be able to make sure that we get that right medication at the right time, the right dosing to the right patient. Okay, so and a lot of that is going to come down to better coverage for our patients, access to these novel therapeutics. I think that second part, which we've alluded to a couple times in this discussion as well, is I really hesitate because I don't want a patient to hear this podcast and think, look, remission might be possible and stop their medication the next day. Right? So I think it's really important for this to be a discussion with your dermatology provider, whether it's psoriasis, eczema, HS, or any of your other inflammatory skin diseases. I really think we're well on our way to finding a way, whether it's to stay on treatment or off of therapy, to get to that remittive state. But this has to be a team effort with our scientists, with the dermatology providers, and with the patient.
Well, it's an exciting time to be in dermatology, Joe. I think you would agree. I mean, we've just got great options and I'm excited to see what the future holds. Like you said, I think remission is going to be our goal. And it just was a novel concept years ago. And to think we're here, how incredible, right? That we're here for our patients. Well, I want to thank you so much for coming on the podcast, Joe. It's been great. I think you've really put this in perspective for all of us.
Thank you, Shannon. The pleasure's mine.
Likewise. And stay tuned for the next episode of Derm-It, Don't Swear About Skincare.
Thanks for listening to Derm-It. For more about skincare, visit dermittrotter.com. Don't forget to subscribe, leave a review, and share this podcast with anyone who needs a little skincare sanity. Until next time, stay skin smart.